from the USA, thrombectomy of carotid dialysis access, new kids on the block.
Thank you very much. Thank you to Dr. Kamel and Dr. Saad and the rest of the organizers for this. It's hard to follow those two great talks. What are the new kids on the block? I don't think there's very many good ones. D-clots usually make everybody very unhappy in the middle of the day, but I'm not sure what's going on here. I'll just go through how we typically do, or I do my D-clots, and you guys can tell me if there's something different in your approaches. Disclosure slide. So we think about D-clots, thrombectomy. What is the type of access the patient has? Because sometimes that may negate some of the tools you may use or what you have to think about. We do a lot of hero grafts. I'm not aware if that's very common here. These are last stage access options for dialysis patients. So when you have a thrombosed access, what are your options? You have plain balloon angioplasty, mechanical or pharmacomechanical, thrombolysis, and aspiration. So, for me, in a D-clot, in a thrombectomy situation, I think balloon angioplasty for an entire thrombosed system is probably not the best approach. You're basically just smashing the clot against the walls, and basically you're going to send that clot flying unless you use some other adjunctive technique. So just using plain balloon for the entire D-clot may not be some of the best you can do for these patients. These patients on dialysis have a lot of pulmonary hypertension, and you continually send a lot more clot centrally, you can cause them to have progressive pulmonary issues. When we talk about mechanical, some of the things we use, Fogarty balloons, we use this consistently for our arterial end of the access to pull the plug. If you use it centrally in the venous circuit, you're just basically going to push a lot of clot, so I would not recommend it, although I've seen people do it. The Teratola device we had for many years, it has good use, but it had limited coverage for aneurysmal fistulas or a lot of thrombus, where you had to use a lot of manual compression to help macerate some of that clot. There's some issues of device failure and all that, and also it's not in the market for us right now. And then aspiration has been attempted with different devices. I'll show you a few. There's a cost associated with it. We think maybe by aspirating you're reducing how much clot you're sending centrally to reduce maybe some of that chronic CTEPH phenomenon, but we don't know. There's also blood loss consideration you have to assume. Penumbra has a dialysis catheter called the 7D. Pharmacomechanical, there's angiojet and cleaner device. Angiojet, I think you have to use with caution, especially when you're using in the arm. If it goes too much centrally with issues, the same thing we had with pulmonary embolisms. People do use it. It's very cost prohibitive for many people. It's a large system to keep, and the cost is there. The cleaner device is what we have adopted for at least the last 7 to 10 years, maybe 5 to 7 years. And it helps for regular grafts, for fistulas, and even aneurysmal fistulas. It is not over the wire. It is 6 French primarily. When we're doing the D-clot thrombectomy approaches, you think about both accesses that you have for these procedures, the venous side and the arterial side. So for me, how I approach these, first side is the venous central side, get as close to the arterial anastomosis and go centrally. First, always, we check central patency. And then what we'd like to do is, after checking that, is do a pullback with contrast and make sure that where is the problem starting? Where is that focal stenosis and the thrombus? Once we get to that point, as you see here, I switch to contrast mixed with TPA. I take about 4 milligrams TPA, mix it with contrast, and just do the rest of the pullback, because what I'm doing is wherever the thrombosis has started, I'm lacing it with TPA as we're doing the rest of it. That actually helps melt and dissolve a considerable amount of clot in the process. So now you're left with this circuit that has mixed thrombus and some of that TPA and contrast. Now you decide thrombectomy versus whatever your approaches are going to be. This is earlier years when we used to use Teratola device. We would use this, we'd run it through there. This is a graft of the venous anastomosis. There are times where we had problems, especially when you have a lot of fellows and residents, get called when the device has separated. That's not fun. You have to go fishing for it. And this example of the device that broke and trying to capture it with a larger sheath. This is the little rubber tip of the device broken off in a graft. It actually got stuck in the vessel wall as somebody was pulling the device through the sheath. I had to go fish that out, do a little bit of surgery. And so these are things that we had to deal with in those scenarios. When we switch to the cleaner, no conflict of interest here, this device does a sinusoidal wave maceration of the clot, breaking it up. The nice thing about it is the larger the space within the graft or aneurysm, it actually expands to a certain degree. So you can actually whip this around throughout the clot. You can see on the bottom right image, this is what it looks like when you're doing it through the graft. It doesn't get stuck on sheets and wires. So it has helped us quite a bit. You can inject TPA through the side if you want to. at the same time to do pharmacomechanical, but it helps us a little bit from the mechanical part of it. You can use it retrograde towards the arterial anastomosis if you have to. Now, balloon maceration, this is a fast one, but just to show that you have to do several balloon inflations, and go back and forth. You're going to send a lot of clot. The one time I will consider using this is if there's a severely stenotic access, like a fistula, and you're going to have trouble with these devices, the thrombectomy devices, or a lot of pain. Sometimes in those cases, it's best to have 2-wire accesses, arterial and venous, and do everything with balloons. It'll take quite a bit more effort when you're using just balloon for your maceration attempts. Now, when you're using aspiration, this is using that Severn French device. You can get clot out, and this is what you get. Sometimes I'm sure there was probably more clot in the system, but this is what came out. You may just be pushing the rest of it centrally. But you do the same thing as you would do with any other device. This is going from the venous side. This is another one. I'm sure there's far more clot. We did this many years ago to just test it out. It is expensive to use this for declot, especially these patients come sometimes once a month, once every 3 months, or whatever they come with. So using this as a sole purpose may not be the best. Some people use just sheath aspiration. I don't know if that's going to be as helpful. So once we've treated the outflow venous side, go retrograde, and this is typically where we will use a Fogarty balloon, get into the arterial side of the system, and then pull the plug. And as you can see here, you have retrograde, not much flow coming through your system. Take the balloon, which you see in the top left image, and then once you pull it 2-3 times, you may be able to reestablish flow. This is sometimes when you get it clear and everything's beautiful, that's fantastic. This is what it looks like. Now, sometimes when you're pulling it, you may actually find areas of stenosis or disease that you may want to keep note of, that you may have to go back and do additional ballooning or intervention. After you do that, you may get multiple flow through there. If you have an aneurysmal fissure that's fully thrombosed, these are very difficult ones. In these patients, the threshold, you may want to consider thrombolysis, either for a few hours or overnight. When you have this much clot within a large fistula, the thrombectomy devices may not succeed. You may not clear all of it out, and you put the patient at a little bit higher risk. So in these cases, such as the bottom right, we put lysis catheters on both directions, drip them overnight, and you may be able to resolve it. We tell those patients after a week or two of it being down in an aneurysmal fissure, you may want to consider that they may need a surgical revision to a graft or something else, but it's still worth an effort if you can restore that patient's access. It's still something very critical for them. Now, great talks already on treating line, but in the midst of a thrombectomy and declot, you have to treat what's there. Dr. Camel and Dr. Lee had talked about DCB. I do think in a fistula, a DCB is a great idea to help you with these stenosis and the outflow. In a graft, sometimes there's a surgical component to the narrowing. You may need a scaffold, such as a stent graft. So just keep that in mind. The DCB works well if you vessel prep, but you can't always vessel prep a venous graft anastomosis that well because there's a little bit of surgical scarring going on. And you just have to think about if you have to stent it or not. So some of these cases, we're not against putting a Viabon short stent. The problem then is that you're going to continue occluding just beyond the stent, and you're going to have to keep extending. So keep that in mind as well. You may have to stent the inflow as well. After you do the thrombectomy, you might find that there's hard thrombotic plaque that never can resolve, and the balloon won't take care of it, so you might have to stent that area. Terminal cephalic, we already talked about. Similar things, stent grafts do well if you don't think DCB is going to be enough. Not recommended to do bare metal stents in that area with the high flexion. You can see stent fractures. So if you're doing thrombectomy, it also makes it very difficult to get through these fractured stents. This is a new device that's being used in Europe that we just started utilizing at our place as well. It's kind of a hybrid between a scoring balloon and a cutting balloon. And basically you put this cage beyond the lesion and you do a pullback with this device, and it seemingly do very well. One of our good friends, Jerry Sullivan in Ireland, loves this and says it's helped his venous interventions and his dialysis patients significantly on getting those stenosis to really improve. So this is at least a new tool besides aspiration. So more to come. This is a patient that we did recently, stenosis, you can see near the elbow joint, and use the device. It's a little hard to see, but this is the device right here. The cage is opening up and you're doing a pullback and allowing these little blades in there to kind of release that scar tissue. And then you get a resolution, and then you might want to finish with a DCB and hopefully avoid scaffolding as the entire goal of going about this approach. Hero graft, thrombectomy, declots, hero grafts, they go down fast, but they open up very easily as well. This nitinol component almost never has thrombosis, should not have thrombus in there. So we will do just the graft component with the same approach, thrombectomy, pharmacomechanical, pull the plug, and usually that's all you have to do. Some of the issues with thrombectomy devices, when you have a delaminated graft from injury, from repetitive use, that might be a situation where you have to consider. We will put stent grafts in a graft as long as there's enough cannulation zone to use everywhere else along that graft for access. So there's not a lot of new kids on the block for thrombectomy in dialysis circuits, but utilizing the tools that you have, you can make this a relatively efficient process. Thank you so much.
Okay, any questions? Okay, welcome our next speaker, Professor Arslan, speaking about challenging central venous occlusion, outside in and inside out, sharp needle recon